we must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Hey everybody, this is Brandon, and for this episode, I chatted with two DPT students who were on their clinical rotations at the Virginia Center for Spinal Sports Therapy while I was working there, and they provided some great insight into their educational experience. So without further ado, here is our chat with Andy Smith and Amara Lim. All right. Hello, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. This is your host, Brandon Pollen. Today, I am actually live at our clinic at the Virginia Center for Spine and Sports Therapy, here with two physical therapy students that are actually completing their second clinical rotations here. And I have the pleasure of welcoming Andy Smith and Amara Lim. So, guys, thank you so much for joining us to really talk about kind of your overall experiences as a student in terms of education, but also kind of your experience in the clinic thus far and kind of really getting some perspective on that. Because I'm just really excited to kind of share a different perspective to our audience here of mostly varied healthcare providers, students, and also faculty members. Yeah. So would you guys kind of just mind briefly kind of introducing yourself to our audience about who you are and kind of what really drove you guys to decide to become a PT and why you went to Radford?
So like Brandon was saying earlier, just finished my second year of Radford's physical therapy program out in Roanoke. So this is our second clinical rotation. The way we do it is we have 12-week rotations, 3 totals, this being our second one. So out in Roanoke, Radford's program, it's the one that I got accepted to, if I'm honest, the only one I got in. But I every day thank God that's where I went because I feel like it's a perfect fit for me. Originally going into physical therapy, I started off as a chemical engineering major at Virginia Tech and decided I hated that. And I was good at math and science and stuff, but maybe it wasn't the right science for me. Was really big into lifting, fitness, and health and all that good stuff. I actually wanted to be a pediatrician at first. My pediatrician was like, you are like perfect for this. You should work with kids. But then some physical therapists came and talked to us at Tech. One of my classes, I think it was like athletic injuries. And I was like, you're telling me that I can do all the stuff that I like and not the things I dislike and potentially peds because there's like peds PT. So I'm potentially still like leaning that way. But physical therapy to me just seemed like a job that I would enjoy doing that's like super fulfilling as well. And it also helps that like my parents and with like seeing like the newspaper, like, oh, like right now it's like top 10 jobs to have. It's like PT was like number 2 as far as like job satisfaction of what people like to do. So that's kind of like what got me probably here.
Very nice. Amara, what about you?
Well, my name's Amara. Like Andy, I'm a second year DPT student going into my third. Well, when I was in college, I actually didn't know what I wanted to do. You know, at first I thought I was going to be a pharmacist, but chemistry was all kind of difficult, so I didn't do pharmacy. Then I thought about computer engineering, and, you know, math kind of got to me. And then my dad got injured, and he went to rehab, and I went to some of his physical therapy sessions, and I was like, you know what, I can do that. Yep, and that's that. One of the reasons why I went to Radford was, you know, I got accepted into it, one of the two, and I actually liked the small program. I know that some other programs had like 60 students, and I like the smaller setting.
Very cool. So I'm going to ask a question that we didn't prepare for initially because I am just so curious because I have never personally experienced a clinical experience where I'm with another fellow classmate. What is that experience like working alongside the same clinical rotation with a similar student in a program? Like, what are some interesting facts about it?
For me, I've really enjoyed it. It's kind of cool because things we'll talk about later too is kind of coming into a clinic. It's like, oh, like I swear I knew this in class, but now I feel like an idiot and I don't know how to do anything. And it's kind of nice to like lean over to Amara sometimes and be like, you're confused too, right? And then she agrees. So for me, it's been great to be like, okay, good. I'm not the only one here that doesn't know what they're doing. I wouldn't say any cons. I mean, maybe in the beginning, if there was ever any worry of like us being compared by like the rest of the faculty here, like I didn't want them to be like, oh, like Amara is great and Andy sucks kind of thing.
I think it's interesting too because you guys are in the same class too.
Yeah.
That definitely would definitely help. I would see if it would be someone like a first clinical compared to their third. I could see how that could be a little bit of a different dynamic perhaps.
Yeah, but since we're both second or we're going to be third years, it's supposed to be on the same plane level there. So that's why it's like you didn't want to be compared in the beginning.
Mm-hmm.
So Andy has a different clinical instructor than I have.
Mm-hmm.
So I actually like asking him, what's he doing, and kind of, I don't know. It's a good,
Yeah, that's a good point. Like I remember maybe after like our second week, we like sat down and talked about what we've done so far and how we've seen different things. Like she sees a lot of concussion patients.
It's all
I feel like I see more of like the chronic pain, more so difficult things to work with. Yeah.
Mm-hmm. Yeah. And I think it's good that you guys are able to see there's different ways, different conditions, but also different ways of assessment, different ways of management, and they're all good. There's reasoning for each one. So I think getting different perspectives and being able to build off of that and collaborate is really good for you guys to consider, especially as you kind of become your own clinician and your own clinical development. So for our audience who perhaps isn't aware, myself included, do you think you guys will walk us through kind of how Radford's DPT program is structured from like kind of the stuff you guys learned from my didactic standpoint?
So we have a 3-year program. First year is all didactic. Then we do our first 12-week clinical. Then we go back to school, do another whole year of didactic, and then a second clinical. Then in that third year, that first semester, it's back to didactic. And then that final spring semester, we have our third clinical.
So it's total of 3 years before we, like that first fall semester starts, we have that summer course of anatomy. I know some programs don't do that. Like they have it like integrated into their program. So ours is like crash course anatomy for the summer, then a year of course, and then the 12-week clinical that summer, and then year of course, 12-week summer, fall, spring is then 12 weeks again. So the 312s, like I was saying earlier.
Gotcha. So how is like the didactic structured in terms of the content? Like you guys go ortho heavy, neuro heavy initially? Like when is a general time frame of when certain things are introduced from that standpoint?
Starting off as a lot of like basics. So it was like kinesiology, exercise physiology, patient management, and theory and practice were classes that kind of, I think, was more all-encompassing, that didn't feel necessarily super basic. I
would say our first year's more kind of ortho.
Oh, yeah. We didn't really touch on it. We had, like, neuroanatomy, I think, our spring semester of our first year. So that was, like, the only really neuro things, or pretty much everything ends up being neuro a little bit. We didn't realize that then. So that was the only time that really felt like neuro. And then the second year.
Our second year was very neuro-heavy.
Okay. So you guys have a lot of like cardiopulmonary, wound care, other systems coming up in the future, or is that kind of been integrated?
We've covered wound care.
Okay.
Our cardiopulm is coming up in our third year.
Did you guys have any opportunities or to participate in any research while at Radford, or was that a requirement?
Both.
Yeah. Both.
So there's positions you could have as like a graduate fellow, research assistant kind of thing, to work with professors and help them with their specific research they're doing. But then also we have like capstone project where we have to get in groups and do research. We're actually in the same group, so it's kind of like lucky to get paired together here because we had to work on that over the summer. So it is required we have the research class where we have to learn how to do that. And do the capstone, but then there is other opportunities as well to work with the professors and help them with their research. I personally have not done any of it though. I don't know if Amara.
No, not me either.
Okay. All right. Is research something you guys want to do in the future or no?
Honestly, after I've learned more about this pain science and brain science, listen to that book, Phantoms of the Brain and stuff, I'm like, what is this? Like, I would love to know more. And like, as I hear about it, I'm like, what? This doesn't even make sense. Like, it's something that I would probably like to read as much as I can about and potentially like look into it further if I ever came up with a neat idea. But I mean, that's something I'll be way in the future because I'm not there yet. But I've never considered research before. I always thought it was kind of boring and stupid until coming here, when it's all about like clinical reasoning skills and challenging things and thinking about where you hear things and like where it comes from, and then learning more about this pain brain science stuff. It's the first time I've ever wanted to look further into things. So it's pretty cool.
Nice. How about you, Amara?
I don't really want to do formal research, but I do like researching on my own time. Like, find something I'm interested in, look further into that. That's about it.
So guys, I know you guys are not through the whole program yet. So I realize this is going to be kind of a limited perspective here. But from your points that you are at now with going through Radford's program, what would you guys say are some of the biggest strengths that you guys have noticed in regards to your program?
As before, the class size, it's very intimate. I kind of like that.
to kind of go along with that, like I said, something that you can't really put on paper very well is like the atmosphere that we have. So a lot of our professors like to have fun and they joke around and they're down to earth. And that's something like when I kind of say like, thank God I got into Radford's program, was that the whole time I just feel like I fit in, like it's a good fit. And it probably has to do with like that small class atmosphere we have going where there's no sense of, there's no sense of competition. Like there is no, like, I don't care to like do better than Amara. It's always this like, I think we're all kind of checking on each other to make sure that we're hanging in there because it's so tough. Yeah. So that's probably one of the best things is that the atmosphere that's been set up where like no one's trying to be better than the next person. Our professors are very down to earth and understanding. To kind of add on to that, our professors are very knowledgeable as well and have so much experience, not just in one field, but like they all have been jumped around a bunch of different fields, so they can kind of give like their ups and downs and opinions on different settings based on what they've done before. So that's really nice to kind of like know that the person teaching you knows what it's like. They didn't just like learn it in a book and then try to teach you what they learned in the book. So like they're constantly being like, okay, this is what you need to know for the test, but understand in the real life it might not look like this. So that has been nice, and we'll kind of touch on that later some probably, but not as nice as I thought it would be, kind of deal.
And I do believe the faculty, they're all still practicing, which I kind of like, because I know that some schools, the faculty just stop practicing. So
So on this show, we like to really go devil's advocate. You know, with you guys obviously going through clinical experiences, seeing the real life practice, what are some things that you think perhaps could be improved in that to make it more beneficial so that you could feel better prepared coming in clinicals?
So for me, one of the like other positives I didn't like necessarily mention is how I feel we do a really good job covering the pathway anatomical approach to things. Our professors are like AOMP, they're all like fellows of AOMP, and they really know their stuff, and we learn like, oh, if it's this, then it's going to be this, like tissue wise, and really understanding those things and differential diagnosis is really strong. But something that has like hit hard coming here is kind of the importance of the biopsychosocial aspect of patient treatment. And while in our program we do talk about that, like it comes up and the professors mention it. Like I said, they'll say like, you know, it's not going to be like this in the real world, but I just never feel like it was emphasized enough. It was more of like a side note, like, oh, it probably won't look like this, or it's not going to look like this, just more of a be ready for it. But then it was never like really stressed. Like we had one class, we have a psychosocial class that was like only 2 credits, and it honestly kind of seemed silly at times. Like, what are we doing? But now like being in clinic, it's like, I feel like that stuff, not that you could necessarily teach it better, but just the importance and the value of it could be emphasized more. Just kind of like, you know, this is half of what you're going to be doing, not 2 credits of your whole semester of what you're going to be doing. But I mean, they do address it. Like we have the course that's on that, and like professional affairs and that stuff. Like we talk about all these things. I guess it's just so hard to take something that needs to be measured objectively in school and then bring it out into the real world. I mean, that's what clinics are for, I guess, is it's the only way you can really get exposed to it.
I would say clinical selection. So I know every school has their issues with their clinical selection, but what we normally did, we had a database where it's all laid out. You know, you pick which one you want, you rank it. But for our third one, we did kind of a new system where she would email out like 4 or 5 locations, and we would pick from that. But I am the kind of person who likes to see everything laid out. I like to see all my options. And by the time I realized that for our third selection, we weren't going to have a database, I was stuck with whatever was left over. So that was kind of upsetting.
It happened to me as well. Yeah. I just like blame myself. I thought I just missed an email or something somewhere, but all of a sudden it was like I had 5 things to choose from, and I thought I was going to get a database to pick at some point in the fall. I think that's what they did with previous years. I mean, they might have told us, and it might be on me. I don't know, but the point is the last one didn't go as well.
Yeah. What was, if you guys know, what was the reasoning behind switching to that approach or system?
I think it's been like a lot of feedback because they've been working on this a lot. Like they want to know what the students want and like what we want to get from the clinical rotation and picking them and stuff. And I think that maybe the feedback led to them thinking that that's the only thing we wanted. We didn't want the database anymore. I think a lot of us maybe wanted to have the option to do either, but then the option was taken away from the database and we didn't know that was going to happen. I think it just might have been a miscommunication thing. Yeah.
So what would you guys say? I mean, with you guys doing your second clinical now, from your perspective, what makes a clinical rotation successful?
Well, first thing, I think you need a really good clinical instructor. I've been really lucky so far in the fact that this one included and my last one, my instructors were so patient with me and I wasn't afraid to ask any questions. So that's one. I know that some people, their CIs were just very intimidating. So, yeah.
I think my CI is probably one of the more intimidating ones, but I was going to say probably one of the important things is like who your CI is, like as a person and as like their education and where they're coming from. So like we both are lucky that we have very experienced CIs that just have years under their belt. So they're not going to get defensive. You can question them on anything and they're going to explain it well because they've looked into the research. They kind of understand more of a deeper, why are we doing things, not just memorizing and doing things. So that's probably one of the big factors, having someone that has that seasoning where they can kind of tell you how it is for real. That being a big one. And then their ability to get you in there and get your hands in there. So giving you the chance to apply the knowledge. A lot of times for us starting off, it was me asking a lot of questions and trying to wrap my head around things. And then he'd be like, I think after a while he'd start to understand, like I'm starting to understand a little bit, like, do you want to give this a try? I think you kind of get what I want you to do here. So that's been really good. But then other things would be like the variety of experiences that you get. So like this clinic sees so many different types of patients, like all ages, so many different types of diagnoses that I've never even heard of. So all between the ages and the types of people and the different diagnoses, I feel like it lets you just see and experience things. Because that's what these clinical rotations are. They're experiences for us to, when we go out there and we're supposed to be the ones responsible and in charge, it's like, okay, I've seen this before. And that's what I think makes a good clinic.
Mm-hmm. Yeah, kind of really transitioning you to ultimately be an independent clinician.
Yeah, exactly.
It's huge. So you kind of both mentioned this briefly kind of in your previous answer in the previous question here, but from where you guys started here at this clinical experience to kind of where you guys are at now professionally, can you walk us through kind of how you guys have each grown? Like where you were at before, where you're at now, and kind of what you're looking to do as you finish up this rotation, maybe go on to the next one, or even when you become an independent clinician?
Well, for me, starting off, it was like I was amazed and confused at the same time. It was like, what in the world? Like, I thought I was good at this. I have like straight A's in school. I know what I'm doing. But then it was like, I have no idea what I'm doing. I just kind of want to sit back and watch for now, because this is all like so much different than like what I learned kind of deal. But to go along with that, I'll kind of like quickly get into like how I grew from it. I started to wrap my head around things. And the best part was just like the ability to question the why behind what's happening and not just take information and try to like memorize it and like take it as a fact. It's more of like, why is it the way it is? And then it improves your clinical reasoning skills, which is like the main thing we can't really have until we're in clinic, I think. I mean, at least that's something that I've kind of seen as like in school. It's like you kind of have to know the facts so they can objectively test it. And then when it's here, when it's like different, it always is going to depend on the patient. That's the answer that you get from every professor when you ask a question. It depends. And it's like, it was always the most annoying answer to get, because it's like, I want to know, but the depends is the right answer. Like if they didn't say it depends, it's like, oh, that person's speaking in absolutes. That can't be right then, because that's what it kind of ends up turning out to be. But for me, it's like, as far as like professional development, like I already mentioned earlier about starting to be interested in potentially looking at research, and I never cared before. It's just this being challenged beyond anything I've been challenged before, and constantly feeling confused has made me want to constantly look into more and understand more. So before this rotation, I didn't really listen to podcasts that much. I didn't really read books outside of what was required in school. So now I was like, I've already listened to, because my drive's a little bit longer to and from here, it's like I've already listened to like 2 audiobooks on like brain and pain science and stuff like that. And then I've subscribed to like 5 different podcasts and listened to those to and from work. And it's all related to physical therapy. And it's just things that's like, you know, going back to school, the before me and the after me is just like so much more ready to take it to the next level when I'm by myself. Like I'll keep learning as a clinician and do that continuing, like the education never ends kind of thing. It's like I always knew that was a thing. I never knew what that felt like until this summer.
Well, for me, when I first started here, it was kind of like Andy's experience. I had no idea what I was doing. Everyone here was so smart, and I felt like I wasn't competent at all. So, you know, I soaked it all in the first few weeks, and then my CI just kind of gradually started having me do things. I started with the subjective, the objective, and then eventually, you know, all of it. So, I mean, it was an interesting experience. It was a huge learning curve for me. Professionally, for me, I think, well, before this experience, I had no interest in doing an outpatient experience at all, an outpatient setting. I really had a bad prior experience in an outpatient setting before, when I was kind of doing my my shadowing hours to apply to PT school. Just the most awful experience. I think that was because I couldn't really do anything, because I was just shadowing for 300 hours. So, but when I came here, there was more to it than what I first thought. And I started looking into more of like the orthopedic side of things, and I kind of enjoyed that. My first clinical rotation was in a SNF, and I really enjoyed that. And I thought, you know, I'm going to do that. I'm going to go in an inpatient or a SNF. But then I came here, and I really enjoy it here. So I have no idea. I'm still deciding. No idea.
No, it's not a bad thing. And sometimes that's why part of the experience is like you learn what you like, you learn what you don't like. So, I mean, there's always value in that. And I think you guys having the experience of this clinic, learning from these two is some of the stuff that they're teaching you, I didn't learn until like a year and a half out on my own or doing a continuing education class when I was back in Michigan. So I think you guys being able to get exposure and know that is so valuable.
Yeah, I definitely feel the same way.
Yeah. So what stands out, if you could choose one thing, what is the biggest thing you have learned about physical therapy profession or interacting or managing patients since you've been a student thus far?
Gosh, picking one thing, that sounds pretty tough.
Patients don't follow a specific pattern.
Ooh.
It depends.
Mm-hmm. It depends.
Like Andy said.
Yes.
Yeah, pretty much understanding the answer, it depends, finally.
Mm-hmm.
Yeah. I'd say the biggest thing is like just clinical reasoning skills. It's just kind of being able to like challenge the status quo kind of thing. Like don't just be told one thing in a textbook and be like, okay, that's how it is. It's just like, it's going to be different with every single person. So I think my big takeaway so far being here is like the importance of like the biopsychosocial aspect of healthcare. And I understand we have to know the pathway anatomical stuff, like one, taking the boards after school, and two, I mean, you do have to know those things because it's going to apply to a lot of patients that have like a tissue issue kind of deal. But it's like, it just turns out there's so much more where it's always like a motor control or like some kind of environmental factor in like the patient's life where like they're coming out of some kind of stressful thing. They're not sleeping, their diet's bad. And like these all are things that lead to what their problem is. But it's just, I think we're going to probably go over that maybe next fall. We have like a wellness class. So that's probably why I'm so shocked at how little I feel like I know about this stuff. But it just turns out more than half of the patient's care is stuff that we don't focus on for boards, I guess.
You know, it's interesting when you kind of go back and you think about, you know, the lessons that you guys have each learned from clinical reasoning, biopsychosocial, being able really to assess that individual person, seeing kind of where they're at and seeing, really assessing on the biopsychol is how much is bio, how much is psychosocial, and digging into those categories, where on all these levels is this person at? Because there's always a little bit of each to a degree, seeing what scale, what's the primary one, you know, and being able to identify. And that's something that definitely gets better the more you see it, the more you experience it.
Yeah, and a lot of this is going to take practice. Like I understand we have to pass boards, and it's like it gives you the right to start practicing. So really it just starts when we graduate. Right. But, you know, it's so hard not to have like terrible anxiety starting off if it's like, if you just feel you don't know how to do it. So it's almost like I feel like you just need more exposure. I mean, that's what clinics are, but maybe just if like maybe during our curriculum, if there was more like maybe forced shadowing kind of thing during the curriculum where it doesn't count as your clinic, but it's like, hey, every other Friday, like, you're going to go work in this clinic for a day. Like that maybe would open my eyes enough. So that way when I am studying the material or when I get this little hint that I feel like professors always give us, like it's not going to look like this in clinic, or knowing to focus on the biopsychosocial aspect of things instead of it just being like what felt like a side note. Maybe if I were in clinic more throughout the school year, not necessarily as a clinical, because I like having these long 12-week clinicals. It would give me the chance to turn my perspective and thought process in the classroom. So as I'm studying, I know what to do with that more as far as like application versus taking it as a fact and trying to store it in my brain for the test.
Right. Being able to use it and recognizing, hey, I know this. Here's how I can apply it for this. I've used it before. That sticks more.
Yeah.
So guys, we usually ask this question at the end of every single episode, and this is kind of a big one, but we always want to see what everyone's perspective is. So the question is, if you could change one aspect of healthcare education, whether that be DPT or other healthcare provider related, which aspect would you change and how would you change it?
Well, I kind of spoiled my answer a little bit there in my previous comment, but pretty much just the importance of biopsychosocial, I feel like. And I know this is talked about for other professions as well, but it's just kind of like treating the patient as a whole. And we say that all the time in our classes too. I guess that just doesn't feel...
I didn't know what it meant when we said in class.
It just doesn't feel like it's emphasized as much. And like you said, it's like not so you're here and living it. Do you really understand it more? So maybe that's the thing. And then also learning how to piece it all together. Like we learn all this information that is really good. I mean, you have to know it. I understand. But sometimes I just feel like it was really hard for me to take, okay, these are the things you look for to get a diagnosis. And like, here's a bunch of treatments and potentially you could use these treatments for blank. But I just feel like it was really hard to understand how to bring those two together. And I guess that's why I'm kind of saying the only way to really see that is if there was like a foreshadowing. And I know that ideally we're proactive individuals. We got into physical therapy programs. We should be able to set up our own shadowing kind of thing. But it just feels like school's so hard and you don't have the time or energy to set up optional shadowing hours, especially when like in school, typically classes during working hours of a clinic. Like I've tried shadowing here and there. It's really hard. But I feel like if we could just had more exposure that didn't count as like the clinical rotation, because I like our long 12-week rotations. I don't want to have a bunch of short ones in between. Just having that opportunity to see these things and having someone there kind of explain like, oh, this person has a rotator cuff pathology or something, and then kind of see why this exercise is the best thing because of this, because then I can take that and apply it to things I see in class. But to go along with that further is like, would be a good one for rotator cuff pathology, but because of this person and their experiences and what they want to do, this would be better. Mm-hmm. And that's something that I feel you can't really get in class. I mean, we try to do like scenarios, which is good. Like I can tell our program really tries to do these things. I think it's just really hard to mimic it in a classroom.
It's the nature of the beast.
Yeah.
How about you, Amara?
I'm kind of with Andy on this. I would have liked more clinical, not experience, but have seen more before actually having been put out there into an actual clinical experience. Maybe like a full week of shadowing before I don't know, just something so I can see how to apply what I learned in school to the real world.
Because it's like we learn how to do like different skills, like piece by piece. Okay, I can do this. But then it's like, I didn't know I should have done this one here. Putting it together. Yeah. And like I said, that's why we're here now. So like, our program has the clinical experience for that reason. So, it's kind of good job there. My experience here is doing great, but it's almost one of those things where if I didn't get lucky and get put here, I like the thought of being at like a different clinic where I feel like I didn't have the education I was getting here with these guys. Like if I were to start off as a PT student that didn't have this experience, I feel like I would just be a nervous wreck, like anxiety to the floor kind of thing.
I think we should have an honest discussion that there's a lot of that does exist out there. I personally, when I came out, I felt like I really wasn't pushed hard enough when I was in clinicals to really be able to be an independent clinician. And when I got out, I felt like it was just a slap in the face. Like you're just like, oh, I have to do all this. And you're trying to learn clinically, you're trying to learn the business, you're trying to learn all this in one. It's overwhelming. And I like how they're bringing, like here, they're teaching you all this stuff to really get you into that role. Because, you can't do it all in one rotation. Mm-hmm. You can't. But you should be exposed and be able to know all the ins and outs of what it's really going to be. So, guys, where can people find you online or on social media if they have a question? Amara, what's your Twitter?
I do have a Twitter. I'm not really active on it, but I do have a Twitter. It's at Amimi150, so AMIMI 150.
Yeah, and probably the best place to find me is Twitter as well. I feel like Andy Smith's pretty too common on Facebook to actually pinpoint me on there, but Twitter would be at Andy Smith VTPT, as in like Virginia Tech Physical Therapy. Even though I am at Radford, it is at Andy Smith VTPT.
What was your quote that you have on there too to identify yourself?
How did I identify? It was like tall, awkward white guy. Yeah. It's like I'm just that tall, awkward white guy.
I love it. Well, guys, thank you so much for your time and perspective. I think it's really good for the listeners to kind of hear the perspective of students that are currently in it and also that are going through a clinical experience, to gain some perspective out there, to get some different points of view out there. Because at the end of the day, we need to have these honest discussions about pros, cons, how can we improve, talk about these real issues to really help get change from all stakeholders. So thank you guys so much for coming on.
Thanks for having us, Brandon.
Mm-hmm.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, Extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.